All right, good evening, everyone, and welcome to the Aspen Young Innovators webinar. My name is Dr. Tim Lubenow. I'm a professor of anesthesiology at Rush University Medical Center, and I serve as senior chair of the Aspen Young Innovators Committee. As part of the function of this committee, it is our purpose to give an opportunity for pain fellows in training to serve as people to train other fellows across the country. And so this particular venue is dedicated to identifying young pain fellows who are in their up and coming prime of their early career to help train other fellows. And so with that, tonight's topic is focusing on regenerative medicine. Joining me is my co-moderator, Dr. Daniel Pack. Daniel, could you please introduce yourself and where you're from, and then please introduce our panelists for tonight.
Sure. Thanks for the introduction, Dr. Lubenow. As you mentioned, my name is Dan Pock. I'm on faculty at UT Houston, and it's a pleasure to be with you all this evening to discuss a topic that is certainly emerging within the field of interventional pain medicine. Certainly gained a lot of traction over the last several years. So, as many of you are aware, regen medicine is employed as a treatment for a spectrum of conditions ranging from chronic musculoskeletal conditions to spine issues as well. So it's an area where there's a lot of heterogeneity in terms of practice patterns and even the literature, as you will find out from today's presentation. So I'm really excited to explore a lot of these topics today. And so we have three excellent panelists who will discuss, among other things, the history, the science, and also the evidence behind regenerative medicine and orthobiologics. It's almost impossible to cover everything in regen in just 1 hour, but we're going to try to do our best here. We have Dr. Vats Ambai and also Dr. John Lee from Weill Cornell, as well as Dr. Alexa Moreira from Rush University. So with that, I will let Dr. Ambai kick off this evening's program by speaking on the history of regen. Dr. Ambai.
Excellent. Thank you, Dr. Pak. I'm Vats Ambai. I'm currently a pain fellow at Weill Cornell in New York. Thank you all for joining here. I'm going to speak on the history of regenerative medicine. Next slide, please. So, regenerative medicine involves using noxious stimuli to induce healing of injured tissues, and it's actually been around for centuries. Next slide, please. If anyone recognizes this bust on the left, that's Hippocrates, the Greek physician often regarded to as the father of medicine, and he was treating unstable joints by poking the ligaments with a hot metal rod. That was actually one of the first steps towards using the body's own healing mechanism to repair connective tissues. This treatment later influenced Roman medicine, where nails were used to transfer heat into dislocated joints of soldiers, as you can see in this image on the right. Next slide. Later in the 1930s, you start to have the introduction of prolotherapy, now sometimes referred to as regenerative injection therapy, or RIT, which often involves the injection of hyperosmolar substances into damaged tissue to induce healing. The history of this treatment involves several players acting in parallel. Next slide. One of the first publications on prolotherapy was in 1937 in JAMA by Dr. Louis Schultz, who studied various injectates, primarily finding success with Plantago ovata, a common source of psyllium. He experimented pretty heavily with animals and injected sodium psyllium all over, including into the left ventricle. He found that the solution induced lymphocytic infiltration, which later led to fibrosis, and these were relatively well tolerated, even if inadvertently injected into the heart or the vasculature. He later went on to perform weekly to biweekly injections for 5 to 6 weeks in patients with TMJ dysfunction and found success in more than 30 patients over the course of the year. These are some of the images from his article. Next slide. That same year, a surgeon named Dr. Earl Gedney published his technique in the Osteopathic Profession Journal. Dr. Gedney purportedly developed his technique after he got his thumb caught in the OR doors. He was inspired by non-surgical abdominal hernia repair techniques of the time, which used irritants to cause sclerosis of hernia defects. Extrapolating that hernia treatment, he was able to heal his own hypermobile thumb injury, and later published this technique along with 2 case reports, where he helped one patient with a hypermobile knee after a femur fracture, and another patient with hypermobile sacroiliac joints after years of lower back pain that was non-responsive to other treatments of the time. The injectates that he recommended in his preliminary report were neoplasmoid or McDonald's solution, and this began the advent of prolotherapy. Next slide. In 1939, shortly after Dr. Gedney's publication, a trauma surgeon by the name of Dr. George Hackett noted interesting findings amongst those patients that had undergone the abdominal hernia sclerosing treatments. The proper sclerosing technique involved injection into the muscular defect. However, those patients that had the injections inadvertently placed deeper past the defect at the junction of the ligament and bone were found to have profuse proliferation of new tissue at this location. Hackett concluded that injections of proliferating solutions could help strengthen weakened ligaments or tendons, and he later went on to coin the term prolotherapy, which was short for proliferation therapy. In 1956, he published the first formal textbook on the subject titled Ligament and Tendon Relaxation, Treated by Prolotherapy, and he also spent a good deal of his time teaching other physicians around the country. Here he is teaching a family physician from Chicago named Dr. Gustav Hemwall, who later went on to also write many textbooks on prolotherapy. Next slide. One prominent individual who was treated with prolotherapy by Dr. Hemwall was a former pediatric surgeon and the Surgeon General for the Reagan administration, Dr. Charles Everett Koop, who used prolotherapy to help with his neck and arm pain. Prolotherapy has since been studied for various pathologies. And although it's often used as an umbrella term encompassing injection of other solutions like platelet-rich solutions or stem cells, the historical term typically refers to injection of primarily dextrose-containing solutions. Next slide. Into the 1970s, we start to have platelet-rich plasma, or PRP for short, emerge. And this is an autologous concentration of human platelets in a small volume of plasma. These solutions contain fundamental growth factors and other proteins that act as cell adhesion molecules for osteoconduction, or matrix for bone, connective tissue, and epithelial migration. Next slide, please. PRP was initially transfused for patients suffering from thrombocytopenia in the 1970s. And nearly a decade later, it was used to repair macular holes and later chronic non-healing wounds. Next slide. Surgically, it was used in oral maxillofacial surgery and other types of surgery, including cardiac surgery, to take advantage of the adherent and homeostatic properties, along with the cellular proliferation properties of the injectate. Plastic surgery uses the treatment for flap survival, and orthopedic surgery uses the treatment for bone healing. This bottom picture here, you can see PRP being used for dental implants, and then the top picture here shows two patients treated for hidradenitis suppurativa, with a picture on the left showing a patient who was not treated with PRP, and a picture on the right showing a patient who was treated with PRP. Next slide. Cosmetic use of PRP began to gain steam in the mid to late 2000s. Here you can see it for hair transplant. Next slide. And then into the late 2000s, PRP was catapulted into the limelight after use by famous athletes and celebrities. Here on the left, you have Heinz Ward, who actually injured his MCL during the 2009 AFC Championship game and was expected to be out for about 4 to 6 weeks, but he elected to undergo PRP treatments and was able to return to the field just 2 weeks later and ended up winning Super Bowl 43. On the right here, you have Tiger Woods, who used PRP several times, one after his ACL surgery, which was complicated because his LCL wasn't healing properly. And then later, he also had PRP injected multiple times for his right Achilles in the winter of 2008, which ultimately helped him avoid Achilles surgery. And he came out strong in 2009, earning Player of the Year, the Arnold Palmer Award, and winning the FedEx Cup as well. Next slide, please. This is a nice timeline showing some of the major uses of PRP over the history of its use. As previously mentioned, it's been used for a wide variety of reasons. Next slide. Shifting gears here to stem cells into the 1950s, stem cells involve the replacement of lost or injured cells while also serving as a delivery vehicle for trophic factors. These stem cells can be derived from human embryos or tissues like skin or created in a mature cell. On the left here, you have Dr. Donnell Thomas, who performed the first successful stem cell transplant in 1956 for his identical twin brother, who was suffering from leukemia, and later went on to win the Nobel Prize for his work. Further research continued in this transplant realm, along with creation of mouse stem cell lines in the 80s, in the 90s with the first non-human primate stem cell line, and then in 1997 with the controversial cloning of Dolly the sheep, which bared ethical importance because it involves somatic cell nuclear transfer to create the embryo. That's where they used an adult cell's nuclear contents and transferred them into an unfertilized egg. Next slide. In 1998, you have the creation of human embryonic stem cell lines by both Dr. James Thompson, a veterinary pathologist and researcher, pictured here on the cover of Time magazine as the man who brought you stem cells, and Dr. Michael Chamblot, a stem cell researcher who didn't seem to get nearly the same recognition. Next slide. Most of what we think about when we talk about stem cells are related to mesenchymal stem cells, or MSCs, which can be derived from bone marrow, skeletal muscle, or umbilical cord blood. However, in 2001, Zook and colleagues from UCLA discovered stem cells in adipose tissues, and this was significant because this was a large reservoir of mesenchymal stem cells compared to the aforementioned sources. The adipose tissue stem cells may have some chondrogenic potential and have been used in OA to rebuild joint cartilage. Next slide. I'm going to pass it on to Dr. Morera.
Excellent. My name is Alexa Morera. I am a Payne Fellow at Rush University. As you can see in the figure displayed, there is a broad range of injectable biologics used for chronic pain, which we'll be discussing today in depth. Next slide, please. One of the most important key players in the regenerative medicine space are mesenchymal stem cells. This diagram shows the various different adult and perinatal sources of MSCs used for clinical applications. Next slide, please. The first injectable biologic we will cover is PRP. PRP, or platelet-rich plasma, is a blood product derived from the centrifugation of a patient's whole blood to produce supraphysiological concentration of platelets suspended in blood plasma. The PRP product is then injected into the site of injury with a goal of supplementing the body's natural healing mechanisms. The role of PRP in regenerative medicine applications is to potentiate the healing process that is mediated by the release of growth factors, including epidermal growth factor, vascular endothelial growth factor, and transforming growth factor beta 1, or TGF beta 1. Next slide, please. Not all PRP is created equal. PRP can be divided into leukocyte-rich PRP and leukocyte-poor PRP, according to its concentration of leukocytes, which is ultimately determined by its processing protocols. The number of leukocytes present is based on the protocol of centrifugation of the PRP product itself. The more rounds or spins centrifugation, the more concentrated the platelet-rich plasma is, and less proportion of leukocytes present in the product. Leukocyte poor is thought to be better suited for osteoarthritis applications as its less inflammatory effects due to the lower proportion of leukocytes in the product. There is debate, however, in the literature for leukocyte-rich PRP, as it's thought to be superior, as it may have a benefit of acting quicker against inflammation. Some argue that there may be more secretion of cytokines with leukocyte-rich PRP that may worsen inflammation. And I'll let my colleagues talk a little bit more about that in the later sections of this webinar. Next slide, please. Autologous condition serum was first introduced in the 1990s and was used primarily to treat musculoskeletal injuries. The preparation of ACS, or autologous condition serum, involved more than minimal manipulation, and therefore this product is not approved for use in the United States. ACS is a cell-free blood product that is rich in anti-inflammatory components designed to treat conditions like osteoarthritis and soft tissue injuries. It's derived from incubating venous blood within medical-grade specialized glass spheres, then separating the serum and filtering it further. This promotes monocyte activation, leading to high levels of several anti-inflammatory cytokines in the product, including IL-10 and TGF-beta 1. Next slide, please. Now, it's important to understand the role and the definition of mesenchymal stem cells. They are cells with the ability to differentiate in vitro into chondrogenic, osteogenic, or adipogenic tissue. They must express specific signaling molecules and be classified as bone marrow or adipose-derived MSCs. The role of an MSC is to respond to injured tissue and can coordinate a healing response via the secretion of bioactive molecules such as angiopoietin, bone morphogenic protein, brain-derived neurotrophic factor, and VEGF, for example. MSCs are thought to have an immune privileged status, also a multi-lineage potential, and have the ability to support angiogenesis in a paracrine fashion. Next slide, please. BMAC, or bone marrow aspirate concentrate, contains progenitor cells, including hematopoietic stem cells, endothelial progenitor cells, mesenchymal stromal cells, that play critical roles in tissue repair and regeneration in chronic pain conditions. As you can see in the figure to the right, this is just an image of a fluoroscopy harvesting of BMAC, retrieving the marrow from the iliac crust. Next slide, please. There's also adipose-derived biologics that we'll discuss. Adipose-derived cells contain a heterogeneous population of cells, including MSCs, endothelial progenitor cells, regulatory T cells, macrophages, smooth muscle cells, pericytes, and preadipocytes, and they're all extracted via liposuction. ADCs, or adipose-derived cells, can be processed in various ways to obtain the following products to then be injected for regenerative medicine purposes. The three I'd like to discuss today are MFAT, or microfragmented adipose tissue, nanofat, as well as stromal vascular fraction. Next slide, please. The first being MFAT, microfragmented adipose tissue, is derived via the mechanical fragmentation of adipose tissue utilizing metal beads or progressively smaller sieves. So this is where you take a sample of lipoaspirate and it is refined to clusters ranging in size from 0.2 to 0.8 millimeters. This processing includes repeated washing with saline to remove lipids, blood, and tumescent solution. This process avoids the use of enzymes and therefore is allowed in the United States and is FDA approved. Next slide, please. Nanofat is another way of processing adipose-derived cells where it's derived from the mechanical emulsification and filtration of lipoaspirate. Components of nanofat are approximately 400 to 600 micrometers in size. This final product is devoid of mature adipocytes, contains microvascular fragments of arterioles, venules, capillaries, in addition to a variety of growth factors, biological peptides, and cytokines. Next slide, please. The last one I'll talk about is, with regards to adipose-derived cells, is stromal vascular fraction. Now, this is defined as a heterogeneous collection of cells contained within adipose tissue that requires the use of enzymes such as collagenases, dispase, trypsin to break down the connective tissue. So the use of these enzymes prohibit this product from being approved by the FDA in the United States, as it is manipulated significantly. Techniques have compared purely mechanical breakdown of adipose tissue compared to the use of enzymes, and the addition of collagenase has demonstrated a 5-fold increase in MSCs, favoring the addition of enzymes. Next slide, please. Amniotic-based products were initially utilized for the treatment of burns and wound healing. Amniotic products, including amniotic membranes and fluid, have been suggested for the use as injectable biologics. Their anti-inflammatory and metabolically active properties allow for subsequent tissue regeneration. Amniotic membranes regulate amniotic fluid, form a protective layer for the fetus, and secrete bioactive molecules, as you can see, that are listed here. Amniotic MSCs consist of fibroblasts and protein complexes that collectively facilitate cellular transport. Next slide, please. Demineralized bone matrix is allograft bone tissue that contains osteoconductive and osteoinductive properties. DBM is harvested from donors containing type 1, type 4, and 10 collagen. It's broken down by host cells, resulting in the release of growth factors, promoting bone growth. It's injected or placed along bone sites of injury, requiring growth and repair. Next slide, please. Then there's bone morphogenic protein, which is one of 2 recombinant BMPs utilized for bone induction in patients. It was created because endogenous human BMP from cadaveric bones have insufficient yields needed for clinical applications. BMPs are a group of proteins in the TGF-beta family that bind to cell-surface serine threonine kinase receptors, activating gene expression for bone creation. Some controversy has been associated with BMP, as there has been reports in the literature of possible neurological impairment, heterotopic ossification, wound complications, and carcinogenicity. Next slide, please. The last biologic agent that I'd like to highlight for the use of regenerative medicine applications are extracellular vesicles. It is a promising therapeutic agent derived from platelets and progenitor cells used to support paracrine function associated with progenitor cells. These are small particles, about 50 nanometers to 1,000 nanometers, which are released by cells in the body involved with cell-to-cell communication in vivo and are found in fluids and tissues in the body. MSC exosomes are derived from MSCs that can be added to cultured nucleus pulposus cells obtained from degenerated discs, which results in reestablishing the normal nucleus pulposus cell phenotype of degenerated cells. And with that, I will turn it over to the next speaker.
All right, hello everyone. I'm also a pain fellow at Cornell, NYP. I'll be talking about some of the evidence regarding PRP, mesenchymal stem cells, and BMAC in pain indications. Next slide, please. So I have no conflicts of interest to report, and these are what we'll be reviewing today. So starting off with medial and lateral epicondylitis, these are studies that I had pulled together and also included from the ASPEN guidelines from 2024 with the evidence-based clinical guidelines for regenerative medicine, graded off the USPSTF criteria scales and grading. So it started with Dr. Alan Mishra in 2006, kind of started off the studies of lateral epicondylitis with PRP. This is a leukocyte-rich PRP, which looked at against bupivacaine, and mostly just a pilot study to see if it was effective, if not that it was efficacious, but also safe. Patients had up to 25 months of relief. However, the control group was lastly large to follow up, so therefore this is really more just like a pilot study of 20 patients. But this study did a good job outlining the methods of the study in terms of how much blood was collected from each patient, how much was with their spinning methods and how much was injected. They even sent the PRP to the lab to see that they were getting about 3.3 million platelets per injection, which is a good target of shooting for over 1 million platelets, or 4 to 5 concentration of baseline for an effective PRP injection. He then followed up the study almost a decade, a little less than a decade later, looking at PRP and bupivacaine as well. This time it was 240 patients in multi-center group study, showing increased pain relief out to 5.5 months. Then Schroeffel and Montalvan looked at ACP, which is autologous conditioned plasma, or another name for leukocyte poor PRP, comparing to saline, and showed no differences in the DASH functional score out to 6 months, and then Montalvan, no pain difference in 12 months. Singh in 2014 looked at lateral epicondylitis with BMAC. There was no control here. It was just an observational study of 30 patients and saw decreased pain out to 12 weeks. Al-Zarani looked at a systematic review of 2 cohort studies looking at PRP and surgery in medial epicondylitis. Here, he showed that PRP had comparable outcomes to surgery. However, none were superior to the other, and both had good outcomes. Overall, because of the evidence from MISRA shows that PRP is a good evidence in terms of superior to corticosteroid injections for lateral epicondylitis, and also medial epicondylitis with Al-Zarani's review. Although for leukocyte poor PRP and also BMAC, just limited evidence for efficacy and limited evidence at all for BMAC in medial epicondylitis. Next slide. In Achilles tendinopathy, evidence is not as robust here. DeVos did a study of 54 patients looking at exercise and PRP compared to exercise plus saline injections out to 24 months, showing no change in pain scores. Stein was looking at open repair of Achilles with BMAC injection concurrently. This was an observational study with good surgical outcomes, showing that it was a safe addition to the surgery. Crow and Boson did PRP studies versus saline. The PRP both of them showed no change in pain or function out to 12 months, showing that overall the evidence for PRP in Achilles is not great. In this situation, unclear if it's the saline as a control that is having more of a therapeutic effect or just a strong placebo effect. Next slide, please. For plantar fasciitis, I think is an interesting indication for PRP due to the risk of fascial ruptures with steroid injections. So Monto did a study with 40 patients comparing PRP injection of 3 milliliters versus 40 milligrams of depot, and showed increased pain out to 24 months. At 3 months, the CSI group and PRP group were similar. However, after that point, the CSI group had a return of their pain. Herber and Daher both did randomized control systematic reviews and meta-analysis. Herber specifically was looking at PRP versus shockwave, steroid, and placebo injections. This included about 1,400 patients and showed that PRP had significant levels of improvement in pain versus all the other modalities. Now, Daher looked at just 6 RCTs with 214 patients, just comparing shockwave to PRP. The PRP group had improved pain at 3 to 6 months. However, just noted that the clinical significance of the significant findings was unclear, as it was a 0.67 change of VAS. When comparing PRP to shockwave, I think it's an interesting alternative to treatment-resistant plantar fasciitis. Shockwave needs to be done typically in a few sessions. It can also be painful, although it is not invasive, but is a multi-week process and also can be costly like PRP is. Next slide. Looking at various other tendinopathies, I combined here patellar, hamstring, and gluteal tendinopathies. Evhart did a systematic review just comparing different modalities for patellar tendinopathy and showed that surgery and exercise had favorable outcomes, while PRP and shockwave were mixed. And actually here, corticosteroid showed no benefit at all. Rodas compared BMAC to PRP. Both groups, and this was 20 patients, so small sample size, but both groups had improved outcomes. However, one was not more significant than the other, but both had no adverse effects. Vetrano looked at patellar tendinopathy as well, looking at comparing PRP specifically to shockwave. The PRP group had improvements at 6 and 12 months, and this was two injections of PRP versus 3 sessions of shockwave. Hamilton did an interesting study looking at professional athletes, which is notoriously a difficult group of athletes to do a randomized control trial. They looked at PRP versus PP, which is platelet poor plasma, and placebo. In this study, they found no change in return to play between the groups. Now, Fitzpatrick's did a study about with 80 patients looking at gluteal tendinopathy that was treatment resistant. PRP was just as good as corticosteroid injections out to 3 months, but up to at the point of 3 months in which PRP had more favorable pain reduction scores. Then a follow-up study showed that at 2 years, they were also continuing to see improved pain results from the PRP group. So overall, I would say that there's inconsistent evidence for PRP and biologics for patellar tendinopathy and hamstring tendinopathy, whereas gluteal tendinopathy may be a little bit more favorable. Next slide, please. Now in rotator cuff tendinopathy, not as many studies, but Dagestar and Kwong looked at PRP versus corticosteroid injections. Both had improved pain at 3 months, but it wasn't further studied after that point, which was a limitation of the study. Kim did an injection with BMAC and PRP combined, looking at exercise, but it did show improvement at 3 months, but no change in tear size. So overall, PRP has been found to be improved for rotator cuff tendinopathy. However, the significance of BMAC is unclear in this situation. Next slide, please. Now, osteoarthritis has a lot more data for it, including PRP. ARIAT looked at 3 injections of PRP versus 12 sessions of PT. The only difference here was the exercise-only group had improvement over the PRP-only group. This was showing that exercise is still a key function in treating knee osteoarthritis. Bilardo looked at comparing leukocyte poor versus leukocyte rich, but there was no difference out to 12 months between the two. He did note that there was more pain and swelling associated with the leukocyte-rich PRP. Now, McLarden did a systematic review looking at a lot more studies and comparing, and found that PRP had improved over his corticosteroid injections from 3 to 9 months, and also sub-analysis showing that 3 injections of PRP was greater than 1 injection. Wang did a follow-up study of the same thing, looking at 12 RCTs, almost 800 knees that were injected, and showed similar findings of increased pain and function and knee OA outcome scores at 3, 6, 9, and 12 months. Dye's meta-analysis of 1,000 patients showed no difference at 6 months, but at 12 months had improved pain in the PRP group and function versus hyaluronic acid. In this study, there was also a sub-analysis showing no difference between leukocyte poor and leukocyte rich, which kind of verified what Filardo had found in 2012. Khalid more recently did a similar study looking at PRP versus hyaluronic acid and steroid injection, and found that they had improved pain and function at 12 months compared to the other 2 modalities. Next slide, please. Next slide, please. Looking at various arthritic conditions, we had Xiang look at PRP versus corticosteroid and hyaluronic acid in knee, hip, ankle, and TMJ. There was no difference in hip OA, whereas they had favorable outcomes for PRP in the other joints of knee, ankle, and TMJ. Saif and Kirshner looked at shoulder arthritis and did leukocyte-poor PRP injections, comparing with improved pain over corticosteroids at 3 months, but no significant difference versus hyaluronic acid. Migliorni did knee mesenchymal stem cell injections. But was noted in the 18 studies that they reviewed, only 3 had a control group. Dye did also a knee systematic review versus hyaluronic acid and placebo, and this one actually showed no improvement in pain or function. Takeaway is that PRP for knee OA is good outcomes compared to hyaluronic acid and steroid injections, whereas for hip it was not so great. Then for BMAC for knee also was limited findings at this point. Next slide, please. Moving on to the spine, looking at facetogenic pain. Wu did a pilot study in 2016 where they had injected the facet joints and saw that there were good to excellent outcomes at 6 months and no complications. So followed up in a larger study with 46 patients a year later, doing PRP versus steroid injections. The randomized control trial showed that they had improved pain with PRP at 3 to 6 months, as you see in the diagram on the bottom left. Now, Caution did a similar study looking at PRP versus corticosteroid injections. And this one actually showed, sorry for the typo on the slide, but improved ODI scores, so functional scores at 6 months. However, the pain at 6 months was not yet significant. Also noted, though, that the PRP group had not yet plateaued, so the thought of the study was that if it had been studied further, potentially at 9 months, they would have showed a significant results, but it was trending in that direction. Just wanted to note here that there was no studies found comparing PRP versus medial branch or RF, which is the current standard treatment for facetogenic pain. In terms of mesenchymal stem cells, there was only a few case reports and case series for facet pain, so not included here. Next slide, please. For the SI joint, not as robust evidence, but favorable. Ling looked at 5 studies, and 3 out of 5 of them showed improvement with PRP over steroid injections after 6 months. Singla did a RCT with 40 patients with leukocyte-poor PRP versus corticosteroid injection. And at 3 months, the PRP group had 90% relief of pain, whereas the steroid group had 25% relief of pain. Devani did a small study with 10 patients, just following patients out to 6 months with good outcomes. And Co, again, only 4 patients in this case series, but followed them out to 4 years actually, which I found was interesting. Was the longest outcome, the duration outcome that was measured. No studies were found for mesenchymal stem cells in SI joint. Next slide, please. Looking at intradiscal injections, I wanted to include this first paper with Obata looking at a rabbit study. They had injected PRP versus saline versus control and found that based on MRI imaging, they had higher water content seen in the PRP disc with increased proteoglycan content and significant reduction of apoptotic nucleus pulposus cells. Schneider did a systematic review analyzing 12 studies. They showed that both PRP and mesenchymal stem cell groups had about 55 and 54% of patients with greater than 50% relief. However, due to the lack of control, it was deemed to be low evidence as a whole. Machado did a systematic review looking at 13 studies. Again, 11 of the 13 had favorable outcomes with pain and function. One of the studies had no superiority between PRP versus saline in contrast, and one was discontinued early due to lack of efficacy. El Kahidri did a BMAC study looking at discogenic and facet pain. Both were injected, and the discogenic group actually had greater relief of pain and decreased use of opiates after 12 months. I think the most interesting study here is Navani, done recently just last year, looking at PRP versus BMAC and saline with 40 patients. The patients were split between the 3 groups, and at 3 months, the saline group or the control was given the option to cross over into either the PRP or BMAC group if they had poor outcomes of pain at 3-month time. So at that point, all of the saline groups was crossed over, randomized between PRP and BMAC, and all had improvement of pains at 12 months, including the original PRP and BMAC groups. From the PRP and BMAC groups, only one of each groups actually crossed into the other group and also had improvement of pain. And so, but there was no difference in improvement of pain between the PRP and the BMAC group. With all these, I think PRP for the disc is favorable and potential to have an effect, whereas BMAC may be effective, however, unsure if it's better equivocal compared to PRP. Next slide, please. So just summarizing things here, we have potential evidence for lateral medial epicondylitis, plantar fasciitis, rotator cuff, facetogenic pain, SI joint, knee and shoulder OA, gluteal and hamstring tendinopathy, whereas I would put hamstring tendinopathy more towards not favorable, and discogenic pain. And then for unclear or poor evidence that we've seen so far is Achilles, patellar, hip, and then other things that I didn't include in these findings, which are muscle strain, diabetic, peripheral neuropathy, spinal cord injury, and radiculopathy injections. And then in terms of BMAC and mesenchymal stem cells injections, the only thing that we saw with potential positive evidence was discogenic pain, whereas the other ones were limited and are poor evidence. The takeaways from my talk today are that regenerative medicine is being pushed widely amongst various facets, as mentioned before. After looking at all of these studies, standardization is extremely difficult. Everyone's using different companies and different methods. Actually, one study actually measured that only 10% of the studies actually include a method section of where they report how their PRP was done. I think it's important that newer studies going forward include this data and something that you pay attention to when you read the data. Leukocyte poor versus leukocyte rich, the debate is ongoing. It's kind of a trend in the field, looking at if you want to cause more pain or reduce pain at the site of injection in the particular patient that you're trying to treat, and in terms of an acute versus chronic injury. But especially in knee osteoarthritis, didn't see a difference between the knee groups and leukocyte rich and leukocyte poor, but we did see a difference between leukocyte rich versus leukocyte poor for lateral epicondylitis. Something to consider for younger patients if you want to avoid repeating steroid injections, especially if there's a risk of a tendon rupture, and just to counsel patients that they may not see the full effects up until 3 to 6 months out. Thank you. And then I'll bring it back to Dr. Ambai to finish us off.
Excellent. Thank you, Dr. Lee. I'm going to take a few moments here to wrap things up with just some future directions for regenerative medicine. Next slide, please. As our knowledge grows, it's likely that we'll have a plethora of components and sources to deliver this therapy, whether that's human-derived or lab-grown mRNA, DNA, stem cells, and growth factors, along with 3D printed components, including scaffolds. And it's likely that we'll have a combination of all of these things at some point. Next slide, please. As we get a better understanding of the human genome, along with understanding of regenerative medicine's mechanisms of action, the optimal types, doses, and frequencies of treatments will only help standardize things like nomenclature, protocols, guidelines, outcome measures, and economic metrics, ultimately optimizing patient care. Next slide. And this is important because we'll be shaping the ethical, legal, administrative, and economic decisions that will help define the scope of what is allowed in the realm of regenerative medicine, if and how it will be paid, and who can receive regenerative medicine. Thank you. I'll pass it over to Dr. Lubin now.
I'd like to thank everybody for their participation tonight and congratulate our panelists for a very robust and excellent discussion on this topic. This is open for questions now, and if anybody has any questions from the audience, you can type in your question to the chat function in the webinar. I'd like to start out by asking Dr. Ambai a question. Is there any level 1 evidence for prolotherapy to give pain relief for up to 6 months or 1 year?
Thank you for that question, Dr. Lubinow. Prolotherapy has mostly been used in research settings. There is some level 1 evidence for its use compared to placebo in things like knee osteoarthritis and TMJ dysfunction. However, when it comes to things like chronic lower back pain, the use of solo prolotherapy for treatment is not supported by level 1 evidence. It may be better suited to use in combination with other things like physical therapy.
Thank you. And then Dr. Moreira, is there any guidance that we have available to, let's say, one particular type of regenerative medicine approach is better than the other? Or is it something that we could separate out that may be better for one type of pain condition versus a different pain condition?
Great question. So when I studied the literature, I saw several studies supporting bone marrow aspirate BMAC is better versus adipose-derived stem cells for the treatment of orthopedic conditions, whereas producing cartilage, that kind of indication, as well as there are more growth factors that were found in BMAC versus PRP, just to kind of keep those things in mind. And also hematopoietic stem cells were better for musculoskeletal injuries as well, is what I found in the literature.
And then Dr. Pack, do you have any questions for our panelists here?
Yeah, I have a question for, I guess, Dr. Lee. You summarized really nicely a lot of the literature on different types of conditions, and one thing that kind of caught my eye was some of the stuff you said about the facets. Now, when they were doing PRP in the facet joints, did it actually detail the volume and the amount of PRP that they were actually providing, as opposed to when we do medial branch blocks or facet intra-articular injections? Usually we're doing kind of small volume. So did you find anything about that when you were looking at the literature?
Yeah, actually, interestingly, Wu's his first pilot study didn't mention anything about the methods of what was actually injected and how much. But that was fixed in the second study, and also Cauchon's study in 2024. They kind of outlined exactly how their PRP was spun, what kind of platelet concentrations they got, which was about 4 to 5x baseline, which I mentioned before. And at that point, they also detailed like that they, how they got their joint access and injected about half a cc, and then the other study was 1 cc of PRP versus the same amount in the steroid form. And they also did diagnostic blocks before including patients in the study, just as we would in the clinic for a facetogenic treatment. But I just want to also reiterate that there was no studies on PRP versus MBB RFs. So when talking to patients about is PRP an option versus going ahead with the MBB RF treatment standpoint, we don't quite have that evidence to kind of guide patients on that standpoint.
All right, excellent. Here's a question from one of our audience members. Is there a benefit, or is there any studies which show benefits of using interventional procedures such as 10x in combination with either stem cell therapy or PRP? And so did anyone read any particular manuscripts regarding any combination of interventional procedures with concurrent administration of either PRP or stem cell therapy?
Not particularly. I wasn't really focusing on 10x in my literature review, but saw some studies regarding 10x for plantar fasciitis. Another treatment where you want to do what you can without causing rupture, and so avoiding steroid injections. So 10x had favorable outcomes for that indication, but I did not see, unfortunately, any study combining that with a PRP injection. But interesting thought, as 10x is kind of like debriding of the tissue with ultrasound versus injecting PRP.
Yeah, sounds like it's something that deserves study. Here's another question that's very topical. Do you think a series of PRP injections should be offered, or should it be alternatively just one at a time and then wait 6 months to 12 months for results and then move forward from there? I believe there was one particular study that gave us some guidance there. Does somebody want to pick up on that?
Yeah, so that was one of the studies from the knee meta-analysis, where sub-analysis showed 3 injections had greater outcomes at 1. I would have to go to see if they talked about significantly how much more clinical significance they've got, rather than statistical evidence. I think that in the real life, you have to consider sometimes these PRP injections can actually cause pain. So would the patient be willing to go through 3 rounds of that versus 1? And as well as paying for 3 times the amount of cost of the injection. I think that's why a lot of the times it's being offered as a one-time injection as first to see, and then seeing how the patient does for a few months before going down another series of injections.
And then here's another question. Is there any information on platelet lysate for epidural injections? And that's a topic I have not seen or heard from. Epidural lysate, did anybody come across that particular topic in their review? I have not heard it. I've not seen that. So if the person posing a question could throw out a reference or something like that. Another question is PRP and lumbar epidural, any particular studies? And I think, Jonathan, you had said that there was some, but it's very weak evidence for that. I would have to concur with my own small scale evidence. It's series, I should say, or experience. It's certainly not anything that is effective in patients who have had failed back surgery, and it has modest improvement in the garden variety people who have lumbar radiculopathy, but it does serve to be another alternative to corticosteroids in people who have unusual responses to steroid injections. Say, for example, the diabetic patient whose blood sugar may jump 100 points or greater in response to the use of steroids, or any other steroid-related side effect that patients may have. Then here's another question. Intradiscal PRP and only for discogenic or also for disc herniation with radiculopathy? And so I think that's kind of related to the point I just brought out, in that the studies that were quoted earlier demonstrate that if you use it for discogenic pain, there is some evidence that it is useful. It's never really been studied in any major randomized control fashion for garden variety radiculopathy from herniated disc, but it can be useful to give, once again, months of relief. And you can administer it whether it be caudal or transforamen or intralaminar, because I've done all 3 approaches. I don't think it really makes a difference as long as you have a good position of your needle close to the area of pathology. I think that's probably the most important. And then here's another question. For osteoarthritis, did any of the studies differentiate between mild versus moderate versus severe OA? And anybody have any answers to that particular question? Jonathan, was there anything that fractionated out mild versus moderate versus severe? Or did they just label osteoarthritis generically for this study?
I mean, there's so many studies. As I was like reading through them, some of them did separate that, but I just don't know off the top of my head between all the meta-analysis. But I think a lot of them were definitely on. They would grade their patients between the 2 groups and like the demographics and how many had like moderate versus severe versus mild. So in the data, it's there.
Yeah. And here's one particular question that comes up at a recent society meeting. There have been lectures or discussions about intradiscal orthobiologics, and can we speak about the potential complications with this approach, like the incidence of discitis? And so we see the issue of discitis that is a recognized complication with any type of procedure where the needle gets close to the disc. So you can cause discitis from even a lumbar sympathetic block if you're inartful from introducing the needle. And so that's just a complication that comes with anything, particularly when you're getting close to a structure that is relatively avascular like the disc is. And so with any type of intradiscal technique, even if it's a straightforward just discogram, there's always this potential for discitis. And so you weigh that. in terms of is a possible complication or side effect when you make that recommendation to patients. And then one final question here, what's the average cost for PRP? I can tell you in the Chicago area, it is a wide variety depending upon who's injecting it. There's, it's kind of like the Wild West. I oftentimes think about it as, I know what our costs or our price is in my particular office, and the orthopedic surgeons in our hospital system, which have been doing this for a much longer time frame, have a different cost structure that pales in comparison, and they do it in concert with many of the sports medicine surgeries that are done. And so I think that that's variable depending upon the environment that you practice in. So with that, I'd like to thank our audience for joining us tonight. I'd like to thank all of our panelists and Dr. Pack for helping me moderate this. It's been mentioned earlier that if you want to do some additional reading on this, there is a review article that was published by Aspen in the Aspen Journal in 2024, and it discusses some of these things and others in greater detail. So if you're looking for something to read about this in more detail, I would encourage you to do that. I'd like to make some announcements about some of our upcoming conferences. We have our annual Aspen meeting in Miami in July of 2025 coming up. So it's going to be an excellent meeting, and there's already been some advertisements out about what some of the topics are. I think the agenda is already published. So please consider signing up and joining us in Miami. As a corollary to that, we are still accepting abstracts to be presented at Aspen, and the deadline is at the end of this month, April 30th. So if you have some study that is worthy of an abstract, please get it in by the end of the month. And then finally, there's the International Pain Society 2025 conference, which is being held in London in the UK in October of 2025. And that particular meeting is now open for abstract submissions as well. So with that, I'd like to thank all of our panelists once again. Just an excellent job. Very proud of you. And thank you to our audience members who signed in and listened. And with that, we'll see you again in a couple of months with our next webinars from our Young Innovators Committee. Thank you.